Hi, everybody. It is 6 p.m. in Paris, 5 p.m. in London, noon in New York, 7 p.m. in Jerusalem. And it is my great pleasure to welcome you all to this ICH webinar. I'm Mohamed Mouti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And the topic chosen for today by the steering committee is something I think you've heard a lot about it in the last few years. And this is related to vaccination against COVID-19. Where do we stand? And actually, I will not come back to the pandemic. It's the COVID-19 pandemic, which has been really a disaster for patients in hematology. But also to many people and families. And actually, we were fortunate that science allowed for rapid progress and vaccination, but also the advent of antibodies proved to be highly successful. And in order to discuss all of this, it is my pleasure to welcome Professor Eolia Brissot, who is also from Sorbonne University and Saint-Antoine Hospital in Paris. And Eolia has done some great job, and she is our reference physician, I would say, when it comes to the management of COVID-19 and its complications in patients with hematological malignancies. And although we are all glad that the situation has significantly improved, but unfortunately, some patients and families are still struggling with this. But again, as mentioned, the vaccination, but for us in the hematology field, I think the use of antibodies against COVID has proved to be extremely successful. As usual, I'd like to thank all our supporters for their unrestricted educational grants, and here special thank to AstraZeneca, but also many others. Of course, it's a live webinar. If you would like to ask questions or share your comments, please don't hesitate to use the chat box. And without any further ado, I'll leave the microphone to Dr. Brissot, and we'll reconvene in 30 minutes or so.
Dear all, it is really a great pleasure to participate to this webinar, and I would like to thank the ICH and Professor Mouti for giving me the opportunity to talk about vaccination against COVID-19, especially in patients with hematological malignancy. So these are my disclosure. And first, I will do just a very quick summary. So the severe acute respiratory syndrome coronavirus, SARS-CoV, emerged in humans in 2002, so more than 20 years ago. And the Middle East respiratory syndrome coronavirus, MERS-CoV, in 2012, so more than 10 years ago. And both these coronaviruses were likely derived from virus strain found in bats. Palm civets and dromedary camels potentially acted as intermediate hosts for the introduction of the SARS-CoV and MERS-CoV in the human population. And you're all aware, of course, that in the late 2019, this new respiratory disease that have been called coronavirus disease 19 because of the years emerged in China, and the disease is caused by the SARS-CoV-2, the RNA virus belonging to the Coronaviridae family. And this new human coronavirus has spread rapidly between different countries and caused of the COVID-19 pandemics, and that's why we're talking about today. So this is just to show that we knew viruses before SARS-CoV-2, especially because when we work with hematological patients, we can find coronavirus that are not that are seasonal coronavirus, and there are billions of cases, but usually the mortality rate is very low, as you can see. 20 years ago, it was the first SARS-CoV-2, so SARS-CoV, sorry, and the mortality rate was high, it was 10%, but you can see that the number of cases was small, only, I would like to say, only 8,000 cases. Like more than 10 years after, it was a MERS-CoV that was detected, and it was highly, a very difficult virus, because you can see that the mortality rate was 37%, so a devastating virus. And luckily, I would like to say there were only 1,200 cases that were detected. And now we talk about the the SARS-CoV-2 that had been detected and among 16 million of humans, and the mortality rate is around 2 and 3%. Of course, because we're talking about patient with hematological malignancy, we know that this mortality rate is higher in our patients. Just a few words about transmission, because at the beginning it was not sure about what was the way the virus was spread. And we know that the spread of COVID-19 occurs via airborne particles and droplets. And people who are infected with this virus can release particles and droplets of respiratory fluids that contain the virus into the air when they exhale, when they speak, exercise, sitting, and it's very important to understand that, because the main way are droplets and also fomites. And so it's why it's very important hand sanitization, the physical distancing, and using a face mask in public areas. And you can nowadays, in fact, there is no adequate evidence of transmission through blood, through urine, stool, and mother to child during pregnancy. And I thought it was important to say, because at the beginning we didn't know exactly the way of transmission, and we thought that the virus was like everywhere. So finally, we know it's by particles and droplets. What about timing of peak infectivity? You can see on this schema, usually, R0 is in fact the capacity of infectivity of the virus. And to know this, there is significant fluctuation in R0 depending on the waves and variants. So it was most important with Omicron when you compare to Delta wave. And you can see that usually patients have the first clinical symptoms. I mean, after 2 or 3 days of the contact with the virus, and the maximum peak of infectivity is between the day 0 and the day 7. And there is a risk of transmission. It's 44% with pre-symptomatic transmission. So it's why the virus spreads so easily, in fact. And there is a low infectivity beyond day 7 and after onset on clinical sign in immunocompetent patients. So because it was quite complicated to know and to determine the risk of transmission, there are simulation tools that nowadays are yes, they are used. I mean, if you are in a hospital and if you are in different firms. But it's true that for one person, it's not really interesting. We know that we need the face, we need to sanitize our hands, and to have physical distanciation when people are have some cold. So, but what about variants? So we know that there are many viral determinants of to do the survival for a virus. They can have surface protein expression and that are modified with the time. There is also viral genome with mutation and host adaptation. And the first, in fact, you can see that the first variant was alpha, then beta, gamma, delta, and now we are Omicron. And the last one is called Juno 1. In fact, and is now I will most of the time talk about the virus in France or Europe because of course it's not the same when you are in different countries. So because the virus of course is doing like its life, so it's not always the same in the same country, as you know. So this is a very interesting source because it's very we have to to say all the variants detection in France, and you can see it was at the beginning in 2023 and at the beginning of this year 2024. Sorry, and at the beginning it was a Omicron variant called B11, and now we have the Juno 1 variants, and you can see that all over the years there were different variants from the first one that were detected. So things are moving, and of course, very important when we talk about vaccination. So when you look, it was the different sequencing by variant in 2024. So it was like less than 3 weeks ago. You can see that the major is Omicron in all country, but there in France, we know that this is a new variant from Omicron that is coming. What about the different clinical presentation? Very quickly, what was very good news is that the probability of being admitted to hospital for patient consulting for emergency department was in fact reduced for Omicron. It was divided by 3. Average length of stay in conventional hospital cares was shorter with Omicron. It got to 7 to 3 days. And the probability of being admitted to an intensive care unit for patient coming from the emergency department patient was reduced for Omicron, 25 versus 8%. And of course, this is one of the major effect of vaccination. You can see on this slide that, in fact, the risk of hospitalization and the risk of death due to COVID-19 in hospital, the main factors is age. You can see that the patients that are above 80 years old have a very high risk to be hospitalized in that COVID-19, but it was in 2021. It's very important to see the date, and the risk of death was really high in older patients. What about vaccines? So in real-world studies, all the studies have consistently provided evidence that vaccines are highly effective at reducing the risk of COVID-19 infection. And even in cases of breakthrough infection, they tend to be less severe and often associated with substantial reduction in hospitalization and death. And vaccination has been associated with lower non-COVID-19 mortalities rate. So it's also very important than non-vaccination after adjusting for confounding factors such as sex, age, race, ethnicity, and study sites. And currently, several COVID-19 vaccines are available worldwide. When you look at this figure, you can see, luckily, there is a global impact in decline. You can see on the black line the number of deaths that is really that decrease over the time, and the number of case when you look at the different part of the world. So now there were higher number of cases in the Western Pacific, when everything is going very low. So it's a good news. And what also is important to understand in COVID-19, that the reported statistics on COVID-19 mortality are always problematic for many countries, owing to variation in testing access first, the differential diagnostic capacity, and an inconsistent certification of COVID-19 as cause of death. And beyond what is directly attributable to it, the pandemic caused extensive collateral damage that has led to losses of life and livelihoods. And you can see that it is, when you look on these figures, this is a percentage of excess of mortality among most affected country when they compare with year before. So even if it's not always written COVID-19, you can see the excess of mortality. This is a proportion of death where influenza and COVID are mentioned in the electronic death certificate, because all patients or humans who died have an electronic death certificate in France, and you have to write the different causes. And so this is really important tool, in fact. And you can see that luckily this is the COVID, and this is the flu, in fact. And you can see that everything is going down, even if there were a little like a peak at the end of 2023. And when you look at the virus, now we have a lot of flu, influenza, and COVID-19, SARS-CoV-2 is decreased, and we can see also a little bit of case of our RCV. It's what during 2 or 3 years we didn't see any cases. And what about vaccination? Because of course everything is due. I'm sorry, it's in French, but you can see that this is age group. So children, small children, young adults and older patients, elderly human. And in France, you can see that older are the people, and better is the vaccination coverage. However, you can see that half of the population is not really well covered by vaccination. What about vaccination? So I know you're all aware that there are 4 types of vaccines. First, there's the virus vaccines, like the weakened virus, and the inactivated virus. The second one is a viral vector vaccine. So there are 2 ways: a replicating viral vector, and the other one is a non-replicating viral vector, but there is no currently vaccine with this way that is in fact we can use. The most vaccine we use are protein-based vaccine, and it's really different, because we use in fact the protein subunit to in fact create antibodies. And finally, the last one was in fact the nucleic acid vaccine. It could be DNA, but for COVID-19, the first vaccine were RNA vaccine, and it was really a great advancement, because it was in fact a Nobel Prize, like I think it was last year or 2 years ago. And nowadays we have 4 different types of vaccine. We have from Pfizer and BioNTech, from their messenger RNA. It was the first one with the original SARS-CoV-2 virus strains from Wuhan. And the other one was from Moderna. So they are a little bit different. And now we have the bivalent, that are the booster dose, because they use the new variant to be more in fact consistent with the variant that they are spreading everywhere. And there are 2 different types of vaccines, Novavax and the other one that use recombinant protein, and they could be used only, they are recommended to be used in France only for booster dose as an alternative to messenger RNA vaccines. So what are the recommendations about vaccines booster? So regardless of the number of reminders previously administered, you have to do booster to people that are at risk of severe disease, including people age 60 or over, immunocompromised patient of any age, adult under 60 identify as being at risk, and pregnant women for the first trimester of pregnancy. There are also high-risk children or adolescents suffering from pathologies like usually immunodepressing, and people living close to or in regular contact with immunocompromised or vulnerable people, including health and social care professionals, and the deadline is for patients who are age 80 or over, or for immunocompromised people, boosters should be given 3 months after, and for the other patient, it's 6 months after. What about adverse effect? You have like local on general local reaction. It's quite common. General reaction are rare, luckily. Usually mainly in patients with a history of severe allergy. However, you know that there were cause of thrombosis secondary to COVID vaccination that was observed after vaccination with adenovirus vector vaccines. And it was a clinical presentation similar to heparin-induced thrombocytopenia. There were vaccine-induced prothrombotic thrombocytopenia, and there were also rare cases of myocarditis and pericarditis. So now we look a little bit of the new publication, like 2 years ago, but about the bivalent Omicron BA1 booster for patients older than 55 years. So it was a big study that was published in the New England, a phase 3 study, and adults older than 55 years old who had previously received the 3 doses of the first common vaccine were randomly assigned to receive, so there were also different doses, but it's not really the main message. The BN2 162b2, so it was the first variant, in the common variant, but they use also the monovalent BA1, and they test also the bivalent BA1. So, and there were a lot of participants, 1,846 underwent randomization. What you can see is that bivalent BA1 was not inferior to BNT 162b2, so it was the first aim to see that there was no inferiority with the bivalent BA1 with respect to neutralizing activity against the ancestral strain. The second point was that the new variant BA4 and BA5 and BA265 neutralizing titers was numerically higher with bivalent BA1 than with the previous vaccine. So the candidate monovalent or bivalent Omicron BA1 adapted vaccines first had a safety profile similar to the first one and induced substantial neutralizing response against ancestral and Omicron BA1 strains, and to a lesser extent neutralized BA4 and BA5 and BA275 strains. So the new bivalent, even in booster, was really an interest for all this population. So what about immunocompromised patient? Because in fact, on people, I think it's why we are here. We know it represents around 2 or 3% of the population. We talk about patients with solid tumor or hematological malignancy who are receive a solid organ or hematopoietic stem cell transplantation. There are also patients with HIV and patients with immunosuppressive medication and high-dose steroids. We know that now all the publications have proved that they are more likely to get severely ill from COVID-19, and they have higher risk for prolonged SARS-2 infection and shedding, viral evolution during infection and treatment. They have a low antibody and neutralization titers to SARS-CoV-2 variants, and 44% of hospitalized breakthrough cases are immunocompromised people. When in this quite small study, in fact, it's interesting, they look at the percent with antibody response and patient with cancer, and in dark blue, it was a patient with hematological cancer, so it was really less than a healthy control. Patients with hemodialysis, in fact, have a good response. Organ transplant have a low response. And for immunosuppressive therapy, it really depends what kind of immunosuppressive therapy patient received. What about this study that was published a few months ago, in fact? The question was the humoral and cellular immune responses to a third COVID-19 mRNA vaccine in immunocompromised immunocompromised patient, because it's really important to do a vaccine, but we are always asking ourselves, and patients also ask, if the vaccine will have an impact, will they respond if they don't have any immunity? And it was a prospective study that was performed on healthcare workers and in immunocompromised patients with a baseline serology following 2 mRNA vaccine doses and who were retested after the dose 3. There were more than 500 participants. Most 492 were immunocompromised patients, and you can see that it was all kind of immunocompromised pathology like solid hormone transplant, autoimmune disease, hematological malignancy, solid tumor, HIV, and there were 44 healthcare workers. And this is a reference from healthcare worker. You can see there is really, when we talk about immunocompromised people, it's like a big bag, and there are really different type of immunocompromised patient when we consider vaccination. And the day 3 significantly increased spike IgG level among host. So the third dose was very interesting because all patients increase their levels of IgG, but seropositivity post the third dose was lowest for solid organ transplant and hematological malignancy. So we can see that there's the two population who have to be really considered with a lot of attention, because even when they receive 3 doses of vaccine, they have immunity, they have IgG, but a lowest level. And when they look at the different kind of test, they saw that the neutralization post the third dose was lowest among solid organ transplant and hematological malignancy patients. Another thing, it's predictor of lower antibodies level, induce low baseline levels and shorter intervals between vaccine. They also look at T-cell responses, because we don't measure the T-cell responses in daily clinical practice. And in fact, T-cell responses against spike increased significantly among healthcare workers. So this is there. They look at secretion of interferon gamma and TNF alpha. And but it was not really significantly increased among immunocompromised patients. However, we have to be careful because the number of patients is quite low. It's only 34 patients with all type of immunodepression, in fact, and these results are quite contradictory with other results. However, they conclude that the third dose significantly improves serological but not T-cell responses among immunocompromised individuals. and solid organ transplant and hematological malignancy patients have suboptimal responses to day 3. So what about the fourth dose? Because time is going, and now we're always asking, do we need another dose? And this study was published a few months ago. It was a Cobra Kai study, and the aim was to investigate whether a fourth mRNA COVID-19 vaccination improved antibodies quantity and quality. This is a study from the Netherlands, and they first screened 723 patients, and they include more than 400 patients. So all the patients receive already 3 doses, and they try another booster, in fact. So two type of boosters. Sorry, it's quite a busy slide, but I'm just looking. What was I'm sorry, it's not the good one. So when first you look at the spike 1 IgG concentration, it was significantly improved after the fourth dose, but remains significantly lower compared to those obtained by when they match healthy individual after the first booster, so the third vaccination. So interesting for this patient. Secondly, they look at all kind of hematological malignancy, because when we have a patient with lymphoma, it's not the same that CAR T cells or allogeneic stem cell transplantation. And you can see that when patients receive an anti-CD20 therapy, during the therapy, there is no increase of IgG level. So, but if if patient receive rituximab, usually less than 12 months before, there were no significant increase of the IgG level. It was the same thing for autologous stem cell transplantation with beam conditioning. And for CAR T cell, as you can see, it was very low level. For CLL, it depends. It depends if you have a patient that is just like watch and wait. And so it increased after the second, third, and fourth doses. But patient with ibrutinib does not respond well, and we know that when they have COVID, it's quite they can be hospitalized, can be complicated. For patients with allogeneic stem cell transplantation, in fact, they really increase between the second and the third doses, but the fourth doses doesn't seem to really doesn't in fact increase the dose of IgG. And you can see that it was when we consider the different type of hematological malignancy, usually the third dose seems very important. The first dose is quite like has to be discussed, in fact. And you can see that ruxolitinib also have an impact on the response. And so in this study, what was very important, I think it was 19 of patients never seroconverted despite 4 vaccination. So we have 1/4 of our patients who don't develop IgG, even if they receive 4 doses of vaccination. Patients who received their first 2 vaccinations when they were B-cell depleted, and the third and the fourth vaccination during B-cell recovery demonstrated similar antibody induction dynamics as patients with normal B-cell numbers during the first 2 vaccinations. So it's very interesting to say that patients receive vaccination during rituximab, and in fact, it is important, even if they don't respond when they receive rituximab, it's important to give them a third and a fourth dose. And a first dose of mRNA COVID-19 vaccination improve spike 1 IgG concentration in the majority of patients with hematological malignancy. And in their discussion, they say that vaccination during B-cell depletion may pave the way for better quality of antibody responses after B-cell reconstitution. And of course, we need maybe more study, but I think it's an important message to say that if you vaccine your patient during anti-CD20 therapy, in fact, there is even on humoral response, maybe a benefit to do it. For patients who receive hematological stem cell transplantation or CAR T cells, there were a review that was published a few months ago, and they said that they look, in fact, that COVID-19 related mortality for patients who receive especially CAR T cell was really high. It is between 34 and 41% of mortality that have been reported, and which is up to 40 times greater than the general population. So patients with CAR T cells are really more at risk to do to go to ICU or to decease from COVID-19. In patient, what about immunogenicity? We just discussed about that, but there is a risk of active cancer therapy that can impact immune response after COVID-19 vaccination. What is important to have in mind is that B-cell depleting therapy, the use of Bruton tyrosine kinase inhibitor and Janus kinase inhibitor has been associated with reduced seropositive rates. And in contrast, tyrosine kinase inhibitors and proteasome inhibitors did not seem to have an impact on the seroresponse. What about patients with allogeneic stem cell transplantation or CAR T cells? When we compare the different, in fact, publication, patients with allogeneic stem cell transplantation have a good, I think, seroresponse. I mean, we have really, vaccine is a major tool for them. And we have to keep in mind that patients who receive CAR T cells have a bad response to vaccines. So to conclude, as COVID-19 continues to evolve, it is important to continually evaluate the immune response and real-world effectiveness of vaccination among immunocompromised individuals. Patients with cancer typically develop a less robust immune response after COVID-19 vaccination than individuals without cancer, resulting in higher risk for SARS-CoV-2 infection and severe COVID-19. In most severely immunocompromised patients, a third dose, a primary series of an mRNA vaccine is recommended, followed by additional booster doses. Recommendations for bivalent vaccine vary by country and region, and administration of additional dose may induce stronger humoral and/or cellular response in this vulnerable population with preliminary evidence of translation to real-world effectiveness. And although both humoral and cellular response tend to increase with additional dose of vaccine, it is important to note that cellular responses can still occur in the absence of a humoral response and could offer a protection against severe COVID-19. Of course, additional studies on the immune response after variant updated bivalent vaccines and vaccination in combination with COVID-19 therapeutics or other type of pre-exposure prophylaxis are needed in patients with cancer. And I would like to thank you for your attention, and I'm happy to take any questions. Thank you.
Thank you very much, Eolia, for this really wonderful and comprehensive talk. And actually, there are still a lot of things we don't know, and it is quite amazing. So we have one question already from Dr. Davy regarding the recommendation when it comes to vaccination in ITP. And let's say ITP is an autoimmune phenomenon in autoimmune diseases in general. Let me expand the question.
Yes. I think this patient, in fact, has been considered for vaccination and should be vaccinated like other patient. It is very important. Of course, we know that this is rare, but ITP can be secondary to vaccination when even a standard vaccination. But this patient has to be really protected from COVID-19. So the recommendation is to, in fact, vaccine this patient.
Excellent. Thank you very much. So we have another question. It's a real life case, apparently, and this is a patient who was admitted for leukemia induction, actually AML, high dose chemotherapy 3+7. And while the chemo has started, actually the COVID-19 PCR proved to be positive, and there are some symptoms. So what would be the approach in this patient? And obviously, I guess vaccine would be useless at this stage.
So thank you very much for this real case in clinical practice. In fact, this is French recommendation. So we know that we don't have any antibodies that are available nowadays that work against Omicron variant. So the only thing there are two things we can do. This patient is in hospitalization, so you can do remdesivir. In IV, you don't have the recommendation to do Paxlovid because in fact is not outside, is in hospital, and you it's the only thing to do and to treat COVID-19 if he has symptoms. But and if the patient begin to have major symptoms and to go to ICU, um, in a clinical trial, you can try to have access to convalescent plasma. And nowadays, it's only a directed therapeutic we can have access.
So we have another question saying, what about the use of Evusheld, which I guess this is the mixture of monoclonal
Yeah.
antibodies.
So it was very useful, like more than 1 year or 2 years ago. But nowadays we don't use anymore. Don't use it anymore because it doesn't have any. It doesn't work on the new variant. So it's useless to do it. In fact, for our patient.
Okay, thank you very much. There's a question from Professor Nagler, who is my co-chair at the ICH. Hi, Anand, asking about whether there are side effects that would correlate with response to vaccines, I get, especially T-cell response.
So thank you very much, Professor Nagler, for this question. I don't really know. In fact, there are side effects that are correlated with the response. I'm not sure because I don't know. When we just look at the patient, we have patients who didn't have clinical symptoms after vaccination and have a really high level of IgG. So I'm not sure we can really correlate clinical symptoms and the efficacy of their vaccination. But if you have any idea, I will be.
But I guess maybe what is behind that patients who develop a sort of a strong immune reaction would do like a sort of a mild CRS or a sort of an inflammatory response. Are there any more side effects, Eolia, in hematological patient when it comes, to other patients who are vaccinated?
No, when in different study, when they compare, they didn't see any difference of adverse event in the general population and patients who were treated for hematological malignancy. So
we have a question here from Mrs. Solène Claverel, who is from Myeloma Patient Europe, so patient representative, and we're very grateful to the great work they are doing to support and help patients, but also educate patient and families. And her question is there a recommendation regarding any waiting time after CAR T to revaccinate patient against COVID-19? And I believe this would be also true, for instance, for auto transplant, for allo transplant. What are your thoughts? What are the recommendations?
Mm. The recommendation I know for allogenic stem cell transplantation is to do um, around the 5th or the 6th months to begin the revaccination. For CAR T cells, it's a different. They say the last recommendation it was between month 6 and 1 year, but what was also shown that patients who did not develop humoral response or IgG, in fact, could develop a T cell response. So I think if I think it's not an error. It's if maybe it's beneficial for the patient to vaccine them quite early to try to protect them with T cell response and to do boost after. So I think um, after 6 months, it can be useful to, and you have to vaccine this patient.
Okay, so we have a question here, and I guess this is related to some data published in 2023 about the AZ3152 COVID-19 long-acting antibody that would able to neutralize all known variants of concern identified to date, which I think there was a press release from AstraZeneca in April about this. Any thoughts on this? Do you think, obviously, something that acts against all variants is great, but is it available? Are you using it? What do you know about this?
I think nowadays it's not available, not in Europe country. Um, I hope I don't say something wrong. I think there is a trial, but we don't have the result yet. But I hope I don't say something wrong.
Okay, so definitely, I think scientific advances, I would say, are really fantastic. We have a question from Dr. Roy about whether there's any cutoff CD4 level predictive of vaccine response in allotransplant.
Oh, thank you. A very interesting question, but really, I don't think we have the answer because first, even in vaccine studies, um, T cell response are not so easily tested. So even in uh, for COVID-19, it was only 34 patients or 50 patients. So it's not a lot. But I have no, I don't know if it has been correlated with the number of T cells, in fact. I don't, I'm sorry, but I don't, it's a very interesting question. But I don't think it has been published or tested to look at the T cell response considering the number of T cells. I'm not sure.
Yeah, I think even outside the field of COVID-19, this has been always like a sort of a continuous debate about the value of CD4 T cells, whether they can predict response to vaccination or whether we can use them as a marker to stop prophylaxis. And I believe we never solved this problem.
Yes.
Okay, so I can see a couple of other questions here. One question is about what are, I think you alluded to it, Eolia, the use of fresh plasma uh, in some cases. Where do we stand here?
Yes. In fact, it's really difficult to have access to the plasma first. And in fact, you have access to the plasma uh, of people who were in contact with the new variant because it doesn't have any interest. So they have to test all the plasma. And nowadays, it's only in clinical practice, in clinical trials, sorry, or for computational use. Sometimes you can have access to that, but there are very low units available. For France, in France, I would like to say. I don't know for other country, but for patients who are still a positive PCR with a low number of CT and who received remdesivir and are still have clinical symptoms, it's a good indication to try convalescent plasma. And we did like for 4 or 5 patients last year, and it was the only therapy that that in fact could make the COVID-19 disappear. So.
Wonderful. Thank you very much, Eolia. It's 10 minutes to the hour. I hope everybody has enjoyed this lovely and timely webinar. I think although the COVID-19 pandemic was a true disaster to all of us, especially to our patients and families, I think it was a good, great proof that science can move very quickly and we can find solutions even to the most desperate situations. So let's remain very hopeful, guys, and thank you for being loyal to the ICH. Thank you for following our activities, and wherever you are, please stay safe and keep well. Thank you very much.